All right, we're good now. Thank you. All
Thank you. 1 second. Okay.
right, so everyone, welcome to the South Texas Regional Family Medicine Grand Rounds. Next slide, please. So thank you in advance for muting your microphone once the presentation begins, being attentive to the presenter and engaging the session, keeping your cameras on when appropriate, registering for CME credit for each session, and completing and submitting a session eval form. Next slide, please. So here's the activity code for today. So I'll leave this up here for a bit so you can all claim your CME credit. And I'll also add this in the chat just in case as well. And then this is can you go back, Marie? So I'll leave this here for a little bit. This is just information how to get the credit via text. So if y'all need to get that. Can you go back one more time, Marie? Sorry, I have to leave this here for a little bit so I can get it. Thank you. All right, next slide, please. So this is just information regarding CME transcripts and how to access those and get that as well. All right, next slide, please. And this is just information regarding the AAFP credit system. Next slide, please. And this is just a slide going over the core competencies. All right, next slide, please. So this is the conflict of interest statement. So Marie Leslie Emmanuel has no financial relationships with ineligible companies to disclose. Next slide, please. All right, Marie.
Okay, I'm ready?
Yes.
Okay. Okay, so my preceptor for this topic for this poem was Dr. Yun Shi, and then special mention Dr. Basil Dua, who I did consult. The topic of my presentation is related to diabetes, as you all know, and it is tight control associated with more frequent and persistent hypoglycemia in elderly persons with diabetes mellitus. So objective here, I think the take-home message for us today is in the elderly, we really want to avoid A1Cs greater than 7.5. So that's the one thing I want everybody to kind of focus in on today. That's today's objective. Glycemic targets as well should reflect patient goals, their current lifestyles, and their life expectancy. So why does this matter? Why is this important? The literature and studies have found that diabetes, as we know, is very prevalent in our society. And it is actually the 8th leading cause of death in the United States. So it's actually very significant for us, as we all do know. And the question that I challenge us to pose ourselves, and which we all have asked ourselves, is, are we actually doing more harm than good when we're very stringent with A1C goals? So our poems, as we know, are patient-oriented evidence that matters. And like I said, our tight control hypoglycemic medications specifically associated with more frequent and persistent hypoglycemia in elderly patients with diabetes. So in my research, I found that it was really actually interesting. There were some 3 RCTs, random control trials, that were done in the mid-2000s that are quite famous. And they were the Accord trial, the Veterans Affairs Diabetes trial, and the Advance trial. The Accord trial was really well known, and if you look, I encourage you all to look that up. It actually found that they had to end the trial early because they found that the intensive trials, that there was increased morbidity with the patient group, that they had intensive A1C with those patients. So they actually, oops, I don't know why I did that, but they actually had to kind of stop the trial early because of the evidence that they found that it was actually very significant, like a stringent A1C goals was related to increased mortality in those patients. Let's see, in the Veterans Affairs trial, that was a 15-year findings that they saw that there was aggressive lowering of blood sugar results, and there was non-significant decline in cardiovascular risk. The advanced trial similarly found the same thing. So basically all trials found that there was not an increased cardiovascular benefit with stringent or lower A1C goals, especially in elderly patients. The advanced trial I thought was kind of interesting because they actually found that there was actually some microvascular reducing effects with stringent A1C. And that's like with diabetic retinopathy, but that was it. So what is hypoglycemia? Why does it matter? Why is it important? The definition of hypoglycemia, what is it? So the ADA and the Endocrinology Society have various definitions for that. I noticed that the Endocrinology Society tends to be quite lower than the ADA, but it's defined as blood sugar less than 20 milligrams per deciliter. And the ADA has 3 classifications for hypoglycemia. So level 1 hypoglycemia is one I think most of us are familiar with, and that's glucose less than 70 milligrams per deciliter, but greater than 54. Level 2 is less than 54 milligrams per deciliter, and that's considered a severe hypoglycemia. Level 3, interestingly enough, is severe events, altered mental statics, or physical changes requiring assistance or intervention. So what are the identifying signs and symptoms of hypoglycemia? So it's divided into 2 responses. One is the autonomic response that we're all familiar with, and that's kind of like the adrenaline response that patients are going to show first. And that's cold, clammy skin, the shaking, maybe some dizziness, some headaches, and then the increased heart rate and palpitations that patients feel. The next set of symptoms that you're going to see in patients are neuroglycopenic responses. And these are attributed more to the level 2 and level 3 hypoglycemic levels. So this is where you're going to have the altered mental status and maybe some seizures, changes in behavior, sleep, irritability, problems speaking, slurring of words, changes in vision, feeling very weak, anxious, disorientation, headache, fatigue. So what are the risks associated with hypoglycemia? I know there's various risks, but based on the literature, about 7 to 15% of patients who are taking insulin have at least one hypoglycemic event a year. And I think I did some research too. There's about 37.3 million of diabetics in the United States. And if it's 15%, then that would mean about 5.5 million have hypoglycemic reactions per year. And that is significant. If they're having 1 to 2% of severe hypoglycemic reactions, that's approximately 500,000 per year. So that's still very significant. This is also associated with very poor outcomes, higher rates of death, and especially noted in older patients. Let's see, they also have a 2 to 3 times higher death rate than those who have not had a severe event. As we know, increases of dementia and cardiac arrhythmias are associated with hypoglycemia. Okay, so the associated article that this topic is based on is entitled Frequent and Severe Hypoglycemia Detected with Continuous Glucose Monitoring in Older Institutionalized Patients with Diabetes. So speaking of the article, in general, it was established, as we all know, hypoglycemia is significant. It's a significant concern in our diabetic patients. And it puts our patients at risk for more cardiovascular events, impairments, increased mortality, and falling. I think the reason too that they did this study was primarily because there was a concern that there was not enough evidence, specifically in institutionalized patients. So they wanted to, that was the question they posed. What is going on in institutionalized elderly patients who are on oral or insulin medications, oral antidiabetics or hypoglycemic agents? So as I said, the goal of the study was that to identify the prevalence of hypoglycemia in these subset of patients who are taking oral hypoglycemics. So they were taking sulfonylureas and another drug called repaglinide as well that is closer associated to sulfonylureas, and to evaluate the relationship between A1C and the elderly patients and them taking those hypoglycemic agents, all the while using a continuous glucose monitor. So the methods of the study, so this is a prospective study. So they were looking at in time and then the future wise, or kind of following the cohort within that time period, which was the 14 weeks. It occurred in 16 geriatric institutions. The age were all greater than 65 years old, and they were taking at least one or more hypoglycemic agent. And it all occurred in the Godoy region of France. So how was the data collected? So basically they made sure that all their patients were diabetic with an A1C, and that they were taking the required medications. And they also had collected biological data, of course, the A1C, serum creatinine, and GFRs. They use a composite scale. So this composite scale is called Autonomy Gerontologic Group ISO resource. It's a French name, but it's actually used in France quite a bit. And this is a scale that they're using to check the functional status of patients. And it's ranges from 1 to 6, and 1 is being the most functional patients to 6 being the least. As I said, they use continuous glucose monitoring. They use specifically Freestyle Libre Pro in the blind mode. And so the patients and the nurses didn't realize what was going on, and they used that for 14 days. The hypoglycemic episodes were defined by the capillary glucose monitors. So everything like the level 1 to level 2. So it was less than 70 for hypoglycemia and less than 54 for severe hypoglycemia. The day times were defined from 8 a.m. to 8 p.m. and 8 p.m. to 8 a.m. So the biostats of the article, so they basically used the chi-squares. We all remember what chi-square to look at the differences between the two groups. And they also use the Kruskal-Wallis test. So the Kruskal-Wallis test was kind of new to me, and that's looking at the difference in groups, the ranking within the groups. But they're both looking at the same thing, whether or not they could reject a null hypothesis or not, and looking at the two different groups. They also use univariate analysis and using the linear regression model as well to look at the relationships between two groups to see if there was a direct correlation or not. Then they use the multivariate analysis performed with the Stata software. And this is in the upper right-hand corner. You can look at that. That's when we're looking at all the different categories and seeing how they relate and intersect. And of course, we have the p-values. So the p-values were less than 0.05 or less. And then we'll see that in the data. Move this over. Okay. So the results. So we're going to look at the demographics of the actual study here. And I'm going to put this over here so I can see better. So as you can see, so I'm going to direct you to the pink highlighted region. So these are kind of demographics of our study. So N equals 42. So there was 42 participants. Interestingly, there were 69% was a female. The mean age was greater than 84. The average A1C was 7.7% plus or minus like 1.1 standard deviation. Let's see. And throughout, well, as we look at the data, I want to direct you to the total. First column is the total, and the second column is the A1C, all less than 7. And then further off to the other columns, so it's going to be A1C greater than 7 to 7.9, and then the A1C greater than 8%. So here, 53% of our population was actually treated with sulfonylureas or the repaglinide. 76, a significant amount, was treated with insulin. So those are the agents, the hypoglycemic agents that were being used. The mean functional status, which is the IRG, that scale I was talking about, was 2.5. So what that tells us is that these patients had a high level of functionality. In the yellow, so these are the hypoglycemic events that they found. So the CBGM is the capillary blood glucose monitoring. That's the traditional pricking. The total events captured manually was 5. And this was in a subset of patients who were not able to continuously use the Freestyle Libre. And then, as you can see, nothing in the minus less than 7% category, and about 1 and then 4 respectively in the A1C of 7 to 7.9 to greater than 8. The hypoglycemic events with the Freestyle Libre Pro, which was significant, the actual events in the whole study was 242 patients, or events, I should say. And that is very significant right there. Just these numbers alone can show us that the ability to capture with the Freestyle Libre was pretty significant, the hypoglycemic events that occurred. And as you can see in the first category, the A1C of less than 7, there was quite a significant amount of events that were captured. It was 129. The second line I will direct you to is the time spent less than 70 milligrams per deciliter in the whole day. And these were the number of events that occurred. So as you can see, so the total number of events, so it's 6 times, I think it's like a fraction. So it's six times, let's see, in the A1C aisle, it was 12 times the amount of times the other categories spent in this period of time. So as you can see in the A1C of less than 7, they spent a far greater amount of time in the whole day versus the other categories, so greater than 7% A1C categories. And I also highlighted that 52% as well. So up to about 9.9%, 52% of those patients spent the whole day with blood sugars less than 70. And we can also see that in the purple highlighted regions, as well as we compare the categories or the columns. You can also see in the A1C less than 7 column, here 18.8 times. They spent a far significant amount of time overnight as well in less than 70 in level 1 hypoglycemia. Okay, so as I said earlier, there was 242 hypoglycemic events. And that was detected in 79% of the patients versus the capillary blood glucose events that were captured. Significantly, 7 patients spent greater than 20% of their time in hypoglycemia. That's pretty significant. And the time spent overnight in hypoglycemia was like 4.5 times than the daytime. And so this is kind of just recapturing kind of what I've talked about earlier. If we're comparing the A1C goals of less than 7 to like the greater than 7 category, as you can see, the asterisks denote the significant value. So these p values were actually less than 0.05. They're about some of them were up to 0.001 in some cases. Oopsies. Okay. Some correlations that they found that I thought were interesting, and I put them on the slide, was a time spent in severe hypoglycemia, so less than 54 milligrams per deciliter, was actually correlated negatively with the A1C goals. So the lower the A1C, the more time some of these patients spent in hypoglycemia. Also, they also found that the number of hypoglycemic events correlated positively with male gender. So that was actually quite interesting, especially in this study where there were so many more women than men. The limitations of the study. So of course, the small sample size, the N was very small. The geographical region as well. So this was in the West region, wine country, Burgundy wine country of France. So that definitely a different demographic than some of our areas. The use of the continuous glucose monitoring system, the Freestyle Libre, from my understanding, they used a new algorithm that was found to have better perception or better improved detection of hypoglycemic ranges versus the other models. Also, time limitation. I think the study was only conducted for 14 days. And I think if we had a bit more data or more studies done, I think I would have given us just more information. So what does all this information, what does this indicate? So it indicates, one, we do need to do more studies in institutionalized elderly patients. 2, there is a higher prevalence of hypoglycemia in the elderly population. As we said, 79% of patients had at least one hypoglycemic event in 14 days. And that begs me to kind of question of our patients in the clinic, how many more of them are having, other hypoglycemic reactions. 45% of the patients spent the entire day in severe hypoglycemia. This was very, very significant, especially if we know the mortality and the association with cardiovascular mortality and dementia. So this is very significant. So what we found too, patients with A1C, as I said, had significantly greater time spent in hypoglycemia, but there was no difference seen with hypoglycemic events like higher than 7. So the 7 to 8 and the greater than 8 category. Also, I think this is giving us a little bit of evidence too, that the continuous glucose monitoring systems might be actually more useful, especially in a lot of our elderly population, at capturing these hypoglycemic events, and giving us a chance to actually do something about it. So clinical application. So what I'm going to encourage everybody to do is use the information that we're learning today to kind of apply it to our everyday practice. So one thing I think we should be doing is de-escalation of hypoglycemic drugs like sulfonylureas and insulin should be done in that patient population. There was another article that I read that kind of supported that as well, that they found, and they used Medicare values, and they found that amongst the hypoglycemic ED events, that the majority of patients were actually, those elderly patients were not de-escalating insulin or sulfonylurea medications. And these were patients who came to the emergency room specifically for hypoglycemic reactions. And so that's kind of giving us more evidence too that we're actually not doing that as a whole in clinical practice as frequently as I think we should. Also, the literature and studies and various organizations like the ADA are suggesting that we actually individualize the management of our diabetes in our elderly patients. So the ADA has something called the Standards of Medical Care. And I really love this graph because I think this kind of shows us visually what we should be targeting. And they have a great app, which I'm going to show all later. But these are the categories that we should be looking at. So the risks potentially associated with hypoglycemia and other adverse effects with other medications. So as you can see, you have the low end of your A1C versus your high end. So there's a more stringent versus a less stringent A1C, and you would kind of titrate that or adjust that according to your patient's needs. The disease duration, a newly diagnosed patient versus a patient who has longstanding diabetes. The life expectancy. So does this patient have a 10-year life expectancy or a longer year life expectancy, or maybe less? Important comorbidities, if they're absent or not. Established vascular complications, the same. Patient preference, I think, is very important. Is your patient highly motivated to kind of, how do they feel about their diabetes? And then resources and support. So this is access to medicine and family support. So this is the app in which I was talking about. And I think this is really nice because it objectively gives us a tool to use to determine if we should be scaling back or de-escalating our diabetes regimen in our elderly population. So it's looking at all those categories I talked about. And then it adjusts, the life expectancy is there, the comorbidities is there, and the individualization, let's see, and then the patient's preference is there, I think, which is really important. So this is nice. Okay, so our objectives after gaining that information. So what I think we should take away from this is that we do need to avoid hypoglycemic inducing medications in the elderly population. So that goes to say A1C of 7.5 is not beneficial for all our elderly population, but we should definitely avoid hypoglycemics in that subset of patients who do have A1Cs of less than 7.5%. The glycemic targets, as that ADA app shows, should reflect the patient's goal. How willing are they to participate, their current health, the comorbidities that they have, and their life expectancies. And so I talk about the scale, and I think that we should be using that objective scale to better help us make those decisions. And then we strongly, like I said, de-escalating sulfonylureas and insulin, which honestly I have not seen done as much. And then evaluating the patient for hypoglycemic episodes. So this is something that we're doing with all our diabetic patients. We're asking them about their number of hypoglycemic events and whether they're symptomatic or not. So something interesting that I also found on doing some research is that there is something called hypoglycemic unawareness. And so I think that's why it's really important that we do talk to our patients about hypoglycemia, the signs and symptoms, and what they do know, assess their understanding of that. Because there is such a thing that some patients do have hypoglycemia and, level 1 or level 2, but they're very asymptomatic. And I think the continuous glucose monitoring system would help us identify those patients. And then also talking about rescue medications. Now, I don't have a slide dedicated to that, but I think that's something that we do need to also, for safety, talk about glucose tablets and glucagon, and these things should be assessed during a patient visit as well. I think that completes my presentation. Does anybody have any questions?
Marie, not necessarily a question, but to your last point that you just mentioned about the glucose tablets, I think we need to bring it up to, I don't know, either Dr. Persani or someone that we actually can't even prescribe it. It's like you can't prescribe this. So
I agree.
I know Dr. Bazaldua has like some glucose tablets, but I think that's something that we can bring up.
I agree. I've been doing glucagon emergency kits for like all my patients, especially the ones who are on a lot of insulin. But I don't see that a lot in a lot of our diabetic patients. So I think that's something that I think all of us need to be aware of, especially since we can't prescribe glucose tablets.
Marie, is that tool that you showed, is that available as an app? I mean, I think everybody always has their iPhone.
Yes,
right?
it is. It is. It's the app. It's this one.
It's called ADA Standards of Care 2023 version.
Oh, thanks.
Mm-hmm.
Can you give us a couple of words about what you found in terms of I think we all know that there's clinical sequelae to very low sugars. So if somebody's at 69 for a few minutes, that's not particularly right. If they're really, really low for a long time, obviously that can have devastating sequelae. It's all that in between stuff that it's kind of difficult to get some feel for how dangerous that is. Did you have any way to help us sort that out?
To determine how dangerous the hypoglycemic reactions were, are you asking?
Yeah, let's say it's how dangerous is somebody gets a 60, I don't get too excited about it. Maybe I should. Somebody gets a 30, I get a little more excited about it. I just want to have a visceral feel for how.
Right. So I think that's what comes with individualization too, and understanding if your patient does have this hypoglycemic unawareness. So I think that's something that we need to take into account, but also the symptoms, right? The signs and symptoms that the patient presents, because some patients are not symptomatic at 70 or at 60 or even at 50. And that's what's more scary, that they're not symptomatic. So I think we have to take into account those factors. The ADA also has something called the rule of 15, so 15 and 15. So whether or not a patient, especially if we know the patient's on medications like the hypoglycemics, I think that's something for us to act on. So we're not necessarily going to react as quickly if a patient is stable and a patient is PO tolerant. So I think that's what we're taking it like your clinical perception. So the rule of 15 states that if a patient has less than 70, their blood sugar is less than 70, you can give them 15 grams of some oral carbohydrates, check their sugar every 15 minutes until it rises appropriately. And so that's like another gauge that we can kind of use in that sense. But I think if a patient is maybe in the 40s and they're totally asymptomatic because of that unawareness that they have, that's something obviously that we need to act on. So I think it's more of our clinical acuity sometimes, and then taking in various factors, the patient's presentation.
Marie, just an additional though about being like asymptomatic, when the blood glucose is as low as 40, I know that might not be likely. I think medication review would be a good idea. Like for example, beta blockers, can mask that hypoglycemic episode. So it could be because they're in a beta blocker, and then that's already like a late sign, so they can crash after that. So maybe that's why they're asymptomatic if we do like a medication.
Right, I agree. That's a
And
great
again,
point.
the importance of like the glucagon rescue and the glucose tablets.
I'm gonna put in a little plug for CGM. So I know it's been out, it's been on the market for years, right? So there is some, I'm sure there are limitations in terms of insurance getting approval, what kind of patient will be the most beneficial. So I think I was just looking up on CMS. So as far as their beneficiary, these patient has to be, I guess they define as has to be on insulin, because I guess the sulfonylurea treated patient won't qualify in there. Hopefully we can de-escalate. And beneficiary, if you have a history of problematic hypoglycemia with the documentation of either severe recurrent level 2 hypoglycemia or history of 1 level 3, those will make them eligible. Just FYI.
Excellent presentation. I just had a quick question. So sometimes we celebrate hemoglobin A1C of 6.5 or 6.4, and we say, yes, excellent control. But I wonder if we should be maybe decreasing some of the doses of the medications that are getting us there, particularly for elderly patients who may or may not be able to recognize their hypoglycemia, particularly if it's happening at night, where they have a high risk of falls or other problems. So would you want to comment on not necessarily people who are having hypoglycemic episodes, but who may be on multiple medications and they are living in A1Cs that are 6.5 or 5.4, and perhaps they no longer need those medications, and we need to back off, and how should we approach that?
Marie, are you going to comment?
I'm done. Should I continue?
Oh, I guess Dr. Hyan's question.
I'm sorry,
gonna
maybe I
just
didn't hear his
take a stab.
question. I'm having like
okay.
audio
No.
issues too.
Oh, no worries. I think his question is regarding when a lot of times we're excited with lower than 6.5 A1C. Maybe in elderly patient, we need to take a very strategic approach of de-prescribing, because maybe tighter A1C control, like you said in this study, have worse outcomes.
Right, so more leniency, right, depending on the patient's comorbidities and the medications that they may be on.
Yeah, I would definitely do a thorough MET-Rec and trying to get rid of meds that are having more serious side effect potentials, right, over time.
Correct, yeah.
Okay, I think we have one more presentation. Maybe we should move on to the next.
Okay.
Thank you,
I am
Marie.
going to continue for Valentina is our next presentation.
Okay, I guess I can share my slides and then or take over this. What should I do? Yes, if you're able to share your screen, let me know if you have issues though. Okay. Can you guys see the PowerPoint?
Yes.
Okay. All right, so this is the conflict of interest statement for her presentation. Valentina Godoy Forero has no financial relationships with ineligible companies to disclose. Next slide, please. All right, Valentina. Thank you. All right, so this will be my presentation on, sorry, move these little images. Sorry, I guess the Zoom is kind of covering part of my PowerPoint, but we'll deal with it. Okay, so this is going to be a presentation on one of the articles that was included in the top poems of 2022. The title of the article is Effects of Long-Term Metformin and Lifestyle Interventions on Cardiovascular Events in the Diabetes Prevention Program and its Outcome Study.
And my preceptor for this presentation was Dr. Shi. Okay. Oh, why is it not working? Okay. All right. So these are the objectives. And I just wanted to do a little quick review of why. I mean, I'm sure that everybody knows and understands that diabetes is a huge problem in our country, but I just wanted to put like a little image because I feel like that's better with presentations and also numbers. So 37 million people in the US have diabetes. 96 million adults have pre-diabetes. It's a total of $327 billion in total medical costs and lost work for people with diabetes. And medical costs for people with diabetes are more than twice as high than for people without diabetes. So these are really important numbers, not only for physicians, but also for patients. And this is one of the reasons why the outcomes of this study, I believe, is important for all of us. Okay. So a little bit more information on diabetes and the risk factors. So diabetics are twice as likely to have a heart attack and stroke than those with diabetes, even if their diabetes is well managed. They're more likely to have hypertension, more likely to have high triglycerides and cholesterol. And cardiovascular disease is the #1 cause of death in people with diabetes. So more important stats. All right, so if everybody can just kind of take a couple seconds to think about what you tell your patients when they tell you like, hey, you know, or when you have to tell them like, hey, you're higher for diabetes, you're in the pre-diabetic range, or they want to prevent the delay of progression into a diabetes diagnosis. And I'm pretty sure that this is what came up in everybody's minds. Exercise, lose weight, eat better, or perhaps you may want to start medication at that point. So we're going to get on to reviewing the article. So the article, like I said, the title is Effects of Long-Term Metformin and Lifestyle Interventions on Cardiovascular Events in the Diabetes Prevention Program and its Outcome Study. So the clinical question of this article was, what is the long-term impact of treating prediabetes on mortality and cardiovascular outcomes? So before we get into this article, I kind of wanted to review a little bit of the background of the studies. So the first part of the study is the Diabetes Prevention Program, or DPP. So remember that. The DPP looked at whether lifestyle change program or taking metformin would delay or prevent type 2 diabetes diagnosis. It was a randomized controlled clinical trial conducted at 27 clinical centers around the United States from 1996 to 2001. The DPP participants were randomly assigned to one of the following groups. So one was the lifestyle change group. It included a lifestyle change program that provided intensive training. That's the key word, intensive training, where the participants tried to lose 7% of their body weight and maintained weight loss by eating less fat and fewer calories and exercising 150 minutes per week. The other group was the metformin group, where they were prescribed 850 milligrams of metformin twice a day and were provided standard advice about diet and physical activity. And then there was a placebo group, which included a placebo twice a day instead of metformin, and they were also provided standard advice about diet and physical activity. So the findings of this first part of the DPP study were that people at high risk for type 2 diabetes could prevent or delay the disease by losing weight through lifestyle changes and the dietary changes and increased physical activity. And then taking metformin was also found to prevent the disease, though it was less effective than with the lifestyle changes. Okay, so that's the first part of these studies. That was the DPP. After the DPP, all surviving members, regardless of whether they had developed diabetes or not, were invited to participate in the Diabetes Prevention Program Outcome Study, or DPPOS. And this occurred from 2002 to 2019. And it was a follow-up study. 86% of the people that were invited agreed. So in this study, all participants were offered a less intensive lifestyle intervention. And those who were originally randomized to receive metformin continued to take it until their A1C was 7% or higher. And at that time, their personal physician would determine the appropriate medication for them. And then if patients were taking metformin, let's say from their physician, that was labeled as out of study metformin, but they still included them in the study. And then the following results that we're going to discuss with this article are the results of the 21-year long study. Okay. So, all right, so the outcome measurements, the primary outcome of this specific article was the first occurrence of a non-fatal myocardial infarction, stroke, or cardiovascular death. Okay, then they did study some extended outcomes that included the primary outcome or hospitalization for heart failure, unstable angina, coronary or peripheral revascularization, coronary heart disease diagnosed by angiography or silent MI by electrocardiogram. And then they did electrocardiograms, and cardiovascular risk factors were measured annually on the participants. Okay, so for the results, the patients in the intervention group were less likely to progress to type 2 diabetes diagnosis. And that's kind of talking a little bit about the first outcome. For the lifestyle therapy, they also had less chances of having hyperlipidemia. And then the main finding here is that there was no difference between the intervention group and the placebo group in regard to the risk of cardiovascular death, non-fatal stroke, or non-fatal myocardial infarction. It's not letting me easily go into the next slide. Okay, so this is kind of, I'm not sure if you guys are able to see this graph very well on your screens, but it shows like a visual of the results that we had. So in the green line will be the lifestyle, red will be metformin, and blue will be placebo. So this first, are you guys able to see my cursor?
Yes.
Yes.
All right. So this first graph up here on the upper area is the incidence of major adverse cardiovascular events. So we see that there was more risk for the lifestyle group and a little bit less for the metformin, and placebo was lower. For non-fatal MI, there was a slightly higher risk with metformin and placebo, and lifestyle was lower. For non-fatal strokes, lifestyle had a higher incidence. Placebo was in the middle, and then metformin had a lower incidence. And for cardiovascular death, it's pretty much the same for metformin, and lifestyle and placebo was slightly lower. So we'll go on to the next slide. Okay, this next slide is the effect of metformin lifestyle interventions versus placebo on the cumulative incidence of extended major advanced cardiovascular events. So what we discussed in about 2 slides ago, all the extra outcomes that they studied. So again, lifestyle had a higher incidence compared to the placebo and metformin groups. All right, so we'll discuss some of the limitations from this study. So even though the lifestyle intervention had no benefit to cardiovascular events, there was some improvement with cardiovascular risk factors. And this may be related to the fact that the lifestyle intervention only had the intensive requirements during the first part of the trial, or the DPP study. And then when they were brought onto the second part of the study, that was 21 years long, they only offered like the intensive amount of the lifestyle changes wasn't as strict as within the first 3 years. Next is the out of study metformin may have affected the differences between the groups, especially in those with diabetes. Even though they did do studies on this to see if there was an effect, and it failed to show that there was any sensitivity analysis effect with that. There was also an increased use of statin antihypertensive treatments prescribed by the participants' primary care providers overall, and a significantly lower use of statins and lower use of antihypertensive medications in the lifestyle group, which may have also influenced the results, although the authors say that they did adjustment for medication use and it didn't alter the results, which is interesting. And then, of course, the results cannot be generalized to all of the population with prediabetes, because the participants, in order for them to meet criteria to be included in the study, they had to have both impaired glucose tolerance and an elevated fasting glucose of 95 or higher. And they had to be at a particularly high risk for diabetes development. And then lastly, metformin and lifestyle intervention reduce the risk of type 2 diabetes, but it may not provide additional protection against cardiovascular disease when glycemia, lipids, and blood pressure are well controlled. Will this change the way we take care of our patients? I don't think that it will necessarily change the way we take care of our patients, but I think that the results of these studies can help us maybe give a little bit more evidence when we discuss the potential benefits of starting metformin in patients with prediabetes, and explain how it could potentially help with cardiovascular risk factors and delay the onset of a potential diabetes diagnosis. And I think that these findings can also help encourage patients to add a lifestyle change to help improve their health. I think that when I talk to my patients, we always tell them the same thing, like eat healthy, exercise, lose some weight, take your medications. But I think that showing actual numbers and saying like, hey, like there was an actual study that, had these results, it prevented the progression or delayed the progression to diabetes, might potentially help convince or help encourage patients to make some of those changes in their lifestyle. I'm not sure what you guys think, if anybody has any questions or things that this may or may not change how they treat their patients.
I was just gonna add a shameless plug that we have Metro Health referral for the diabetes prevention program if you see them.
Yes, that is correct. That is correct. Okay. So this is just I don't know. I'm not sure if the images of everybody's video is showing up on your screen or not. But this is just a summary of the points from the results of the study. And then these are my references. Any other questions from anybody?
Well, I had a comment, Valentina, about when you showed the slide with the 4 graphs on it, the one in on the lower right, actually placebo did the best of all, right? And then if you looked at, I didn't see one for all-cause mortality, but it makes you wonder, since it's not the same ones on top, that I would be interested to see how much difference that makes. I think the thing that strikes me about all these is they're all sort of bending up to the north, right? So, and not at, well, in some cases at different rates, not that much different, right? So I think we're dealing with a process that is progressive over, you know, the number of years that you have at the bottom, 20-year horizon. So these things are important for our patients to do, but I think it's also important to keep in mind that whatever we do, these are progressive problems, and we need to, you know, monitor that and manage that.
Yeah, I agree. Good point. Any other questions? I'm done with the with the presentation otherwise.
Yeah, I think I just want to put a comment. I think cardiovascular disease is still a multifactorial polygenic disease, and with a lot of other risk factors where we're not, I mean, we're trying to normalize or take into account all the things we can adjust for. Diabetes or impairment in glucose metabolism is just one of the many, right? So I think it's very impressive that we're able to follow up these patients for 21 years. It's a little disappointing in the final outcome, but I think we still take the positive aspect of the report. It is preventing from development of diabetes. Maybe cardiovascular disease is not the area we see a long-term benefit at this measurements. Maybe there's some not severe, like you said, the risk factors are reduced by certain interventions, right?
Yeah, correct. Yeah, I got really excited about reading the study, and then when I saw the results, I was a little disappointed. But still, there are some positives that you can take from it. So, yeah.
Regardless, it's a very important 21-year prospective study. Yes,
Definitely.
Thank you.
Thank you.
I have a question, comment also. I think it's important to keep in mind that many of the people who participated in the studies are not necessarily like our patients, because in order to stay in a study this long, so I just wonder if you had any idea what was the ethnicity, poverty factors that of the people who were included in the study.
As far as ethnicity, let me see if I can actually bring it up on my but that is a great point, right? And I think let's see.
I think
at baseline
there's a figure. Yes, go ahead. Sorry.
Yeah, it says that at baseline the population was middle-aged with a mean of 51 years. More women at 68% than men. And it was racially diverse, with 54.7 being white, 19.9 being Black, 15.7 Hispanic, and 5.3 American Indian, 4.4 Asian. And it says that all baseline characteristics were similar among the three treatment groups. So, yeah.
Do you have information on insurance status? Maybe a proxy for poverty.
Yeah, I don't remember reading anything about insurance status. Maybe if I can go back to the POEMS article, but let me see if I can bring up the GP study. Oh, I would have to, I think that might take me a while to find that one out.
No worries, I was just wondering.
But that is a good point. There's, because it's not just, diabetes, environmental factors, income factors like that all affects our health, right? So yeah, that is a good point.
Well, thank you both for the excellent grand rounds.
Thank you.